followed by a long-acting, so they can have a long-lasting effect of that triptan. So when you see this in your patient medication, besides you must remember triptans are abortive for migraine, you have to ask your patient, what are you taking to where you really instruct how to take it. The new medications really, or the new generation of medications that you have to be aware of them, because as I mentioned, is a lot of comorbid with other TMD conditions, and around what there was over 15% of the population have migraine, that are these new monoclonal antibodies that are actually going to block the CGRP. The first one that came out were Ajovy and Aimovig, which were injections that were done either uh, one injection every month or two injections every month. As you can, a lot of the medications are having this modality of being injectables. Uh, if you had a reaction to any of these injectables, it takes a long time to get out of your system. So then now we have available the same medications, the same blockers or monoclonal antibody for the CGRP in tablets. And there are two Emgalide, that is a huge triangle pill, or Nurtec, which is like a little sponge that you put under your tongue and dissolve and taste like mint. So be careful, patients don't take it thinking that they are mints, right? But they are abortive, and based on what I hear from my colleagues from neurology ward is that very soon these medications are going to push away the triptans. Obviously, these medications are much more expensive. Not necessarily all insurance cover that. The company is trying to cover the first year of the prescription, but then people have to go through an approval for insurance approval of this medicine. And then I have this here to provoke Dr. Crow a little bit. And she will talk more about these little gadgets when she talks about interocclusal appliances. But many years ago, actually, I got a call from a neurologist asking me if I could take patients to fabricate these NTIs, the tension suppression system. And I know that they have added more letters to the name. Maybe Dr. Crow remember them. I tried not to remember them. But this NTI has been approved at the safety level, so it doesn't cause in a short term any major side effects. But there are some individuals that believe that you can use these to treat migraines based on the suppression of the trigeminal input. That's the fancy words that are used in the videos to present this. But the only thing I can tell you is that we don't do NTIs to treat migraines. We don't want to teach you to do NTIs to treat migraines, and we don't want to teach you to make NTIs at all. And during the lecture of appliances, Dr. Crow will develop more on that, unless you want to make a comment right now. No, that's okay. We can hold off to it. Lester. Notice that I ask for comments every time I want to have a sip of water. But, this probably out of order because there should be at least three slides ahead before that there are some foods that may trigger the headache. So that was another question Dr. Katouf showed you when you were taking the history, right? What triggers your pain episode? So individuals with migraine will have a specific food that will trigger their migraines or that trigger the headaches. And when we see that pattern, we know that it's pretty much confirmatory that being migraine. So, everything that is delicious, chocolate, wine, coffee, triggers migraine, cheese. So, it's kind of sad, but they do. So that was about migraine. So it was very important. Why? Because it's very prevalent in the adult population, even though Cody exposed us to that particular case with one of his patients, and it's less prevalent among pediatric and elderly population. These are not just headaches, but these are very severe headaches that have a genetic and environmental components, and phonophobia and photophobia being pathognomonic of the criterion for the type of headache. And you should know that they have preventive and abortive treatments, and you should be familiar which medications are preventive and which medications are abortive. So this is just a transition slide to go to one of the most common type headaches, which is a tension type headache. I know few individuals that have told me that they have never had a headache. I feel very envious about that. But tension headaches are very prevalent. If you can see in the world, lifetime prevalence goes up to 78%. So, close to 80, almost everybody had a tension type headache in their life. Is described by the patient as a pressing and tightness, and they usually put their hands like this. It's like it covers the whole band, like having a hair band on your head, right? Age from 30 to 50, more present in females than male. They can be episodic and chronic, which I didn't mention for migraine. Migraines are divided as well as episodic and chronic. And the International Headache Society cut it in 15. If it's more than 50 days in a month, they are called chronic, and if they are less than, they are episodic. And a lot of the approval of medications is based in this cutoff of 15 days. They may last for minutes to days. They are usually bilateral in the temporal and frontal region. People will put their hands like this. Present tightening, like somebody's compressing your head. Mild to moderate pain. I don't know. That's how it's described in the textbook. I will say that that's very subjective, but I will keep it right there. No aggravated by routine exercise. These people, their pain doesn't get worse upon that. And no nausea or vomiting associated. Maybe associated with photophobia and phonophobia, the maybe, but it's not. It's both sides. Sinus. It's not that hard pumping on your head, right? So that's as much as I have for tension type, and then allow me to move into the trigemic autonomic cephalalgias, in which many of them are described. We will probably just talk about cluster headache. But there are common characteristics among these cephalalgias, and it's the word autonomic, meaning that there will be autonomic associated signs that are going to be associated to the pain episode, okay? So, or to the headache episode. Among them, lagrimation. So, the patients will say, my eyes always turning in the side where I have the pain. Rhinorrhea, they don't say rhinorrhea, they said the boogers come out of my nose in that side when I have the pain. My eye gets bumpy, they don't call it eyelid edema. They can get very red in that side and sweat in the side of the face. People actually call it like flushing with through menopause. And the eye pupil can change the side. And this is the only time that you will see use a milk picture to identify a headache. Why? Because this particular cluster headaches, I told you there are several, right? And I said I will mention about cluster headache. Well, cluster headaches are more frequently in males. It's been described as the most severe form of primary headache. Again, that's from the literature and the textbook says that, but most severe compared to what? I don't know. Involve sudden, extremely painful headaches that occur in clusters. That's what it's called, cluster headache. So they can have a month with this pain, and then suddenly goes away and they don't have it again. And when they come back, they stay for a cluster, a group of days all together. Um, and usually happens, it says, at the same day and time, usually uh, related to the sleep cycle. Mainly in type A individuals, which are very detail oriented. Let's put it that way. That sounds better than compulsive. Most frequently males, middle age. The prevalence is very low, associated to smoking and alcohol intake, and individuals without a history of headache or a family history of migraine. And these clusters occur more often in the night, suggesting that it must be an interruption in the sleep cycle. That's what I have, that is sleep cycle pictured right there or graph. Um, Commonly 2 to 3 hours after falling asleep. And these people actually tells you, I woke up with this headache, and it's every day at 3:14. They will tell you the time. Uh, Alcohol intake and smoking provokes the attacks, and it could be a relation with previous headache trauma. It seems to be that it have a genetic component related with histamine and serotonin release, which is similar or common to migraines with auras. And then you have this Horner syndrome, in which one eyelid will drop and the pupil, as you can see, will get very small. So, this is taken from the internet, but this is how you will see this patient. And we have one recently. I don't know if Dr. Katouf remember that lady, and we could see this, and you will put eye, and it will not light, and it will not cause any changes in the pupil. Okay. What is the treatment? Actually, one of the DCRP antibodies has been approved by FDA for the treatment of cluster headache. That's the Megalite. But also the use of triptan has been used for years to avoid these clusters, and the use of oxygen. And the oxygen is 7 liters per minute for 15 minutes, which in a way is very cool, because if you have in your chair somebody that you may think is a cluster headache, we could administer the oxygen to see if we could actually break the episode of the headache. Any questions so far? And I want to see the time. How are we doing? When I'm sharing the screen, I don't see the time. I don't see anything. This is very weird. But anyway, let's move into neuropathic pain disorders. Maybe Ana Maria has a question? No?
No, we're good to go.
We're good to go. What about Pedro?
No.
Pedro has no questions. Very good. So in terms of neuropathic pain disorders, we will talk about the classical trigeminal neuralgia, which is one that you must know upside down, because when you finish dental school and you go to your programs in different hospitals, different specialty programs, believe me, they will call you to confirm if it's trigeminal neuralgia or not. Glossopharyngeal, prevalence very low. We will talk about atypical odontalgia, and next week Dr. Crow will talk in detail about burning mouth syndrome, and she may involve other neuropathic pain disorders if she wish. So let's start with trigeminal neuralgia. I know it's very hard to see, but what do you see? Obviously, you see a patient touching her face. Can you see the other intraoral picture that is not from this particular patient, but is characteristics of what we may see in patients with trigeminal neuralgia? So now I ask questions. What about Rebecca? Rebecca, are you with us?
Which Rebecca?
Rebecca, I take any Rebecca, I'm not picky. I was reading, yeah, go ahead.
Yeah.
see, remember, there are no wrong answers in this course during the Zoom meetings. The exam is another story. But during the Zoom meetings, what do you observe in that intraoral photograph?
It's a little dark. I really don't see.
I agree. It's a little dark. But
can't
remember, you are an expert in the mouth, so you guys look at the mouth and you see things that other people don't see.
Are those white areas of like candidiasis?
White area. No, that's no white area. That's a reflection of the light. I must say that. But yeah, what you identify as white. Let me find my mouse again. I guess you talk about these linear things. Those are a reflection of the light. Very good. One more chance. What other thing do you see?
Is that a cavitated tooth on the upper right?
You see what?
Is that a cavitated tooth on the upper right? there?
Cavitated tooth in the other side. You are talking about these ones here? Yeah. They have some restorations. So that means somehow this patient has been in the dentist. I agree with you, right? It's been in the dentist, it's been receiving some kind of restorative work. Okay, very good. Let's go to Joseph. And if it's more than one, I take any Joseph.
I'm here.
Go ahead, Joseph. What, in addition of what Rebecca observed, what do you observe? Joseph, are you there?
On the left. Can that have anything to do with it?
I'm sorry?
Can the missing teeth have anything to do with it?
Missing teeth. Very good. I like that because so Rebecca said, look, this patient has been receiving dental care. So the likelihood that in this side the teeth will not be restored is very low, right? Because they restore this side. But suddenly you see this kind of healing. It's still this one is not fully healed, neither this one. So they've been recent extractions. Very good. So between Rebecca and Joseph, they answer what I wanted. Meaning this individual is receiving second molar out, first molar out, second premolar out. And quite recent, at least between these two teeth. Why? Because these people are coming to tell you, I have this pain, I cannot stand it, it's driving me crazy, I never had anything like this, please pull it out. But we can do root canal and a crown and a new restoration. No, I don't want to deal with that, please take it out. I promise you, it's that tooth. Poof, tooth out. A week later, the pain is back. Oh, I don't want to go to Dr. Rebecca again, I promised her it was that tooth. Let me go to Dr. Joseph. Dr. Joseph, I saw Dr. Rebecca. She's very nice, very sweet. I love it. But I don't want to see her again because I told her it was this tooth, but I now know it's this one, the in front of it. And then Joseph said, but it's a small restoration. You come next week, we can, no, take it out. I don't want to deal with this pain. Kataplum, boom, out. And then 2 weeks later, she goes to Dr. Megan. I saw Dr. Rebecca and Dr. Joseph. They are fantastic. I love them. They're so cute. But it wasn't those two. It's the one in front. And these individuals actually receive what I'm trying to describe, multiple dental extractions because they are efficient for the pain. And they, in fact, can feel that the pain is on the tooth. But it's no tooth pain. It's not odontogenic in origin. So the next time you see a patient like this very poor picture, that you really have to pay attention, that's what I want you to do, to really pay attention and look and don't take the next tooth out. I have had patients underneath asking me to pull out the next tooth, and you have to stop because it's not odontogenic related. So based in that story, I want to tell you that trigeminal neuralgia it's been a condition that you can see, you can read right there since 1677 is one being presented and has been studied. Okay, it's more present in females. And most of the time, 95% of the time, thank God, is unilateral. It's unilateral. It can involve any of the three branches of the trigeminal nerve, but rarely the ophthalmic. I think we see mainly the maxillary-mandibular brain. Okay. The pain is spontaneous or triggered by a non-painful stimuli. You have to highlight that. So these are the individuals that says, if I brush my teeth, the pain comes. If the wind coming from the, if you are walking from the train station to the dental school, that cold air triggers my pain. So they wrap their head like mummies. They don't want the cold wind to hit their face. If I shave, I don't shave, I promise, not yet. But if I shave, that triggers. If I put makeup, so people come with makeup in half of the face. I only make up this side because if I put makeup in the side, I will get my pain, right? So non-painful stimuli will trigger the pain. How is that called? I mentioned that non-painful stimuli when we were talking about temporal arteritis. What is the other word for that?
Allodynia.
Thank you, Andre. You make my day. Very good. Sharp shooting pain, and actually, I think mostly electrical type of pain. That's what I hear from my patient. It comes like a and goes away very quick. And they may say that there is a background pain, kind of a dull pain, but it comes like an electrical thing very quickly that goes away very quickly, right? It lasts just seconds. And they don't know the pain is coming. So it's not like the migraine without it, right? Oh, I know the pain is coming. They don't know. It's boom, spontaneous, comes and as an electrical pain. And when you do your cranial nerve, is normal. It is important as dentists to know about it. Number one, because it's our nerve, right? Although we share a little bit with the neurologist, the nerve, but the other reason for is because patients with MS, multiple sclerosis, it may start as signs of trigeminal neuralgia. That's how their early symptoms will start. And neurologists will tell you that. That it's very important that every patient that you diagnose with TN to make it for the full workup of to rule out that it's not MS, because it's around 18% actually patients with trigeminal happen to be early MS. And that is a family occurrence right there. So why it happens? Like many things in life, we are not sure. That's why it's called idiopathic, although in some cases it's a structural compression of the trigeminal nerve. And when they confirm that it's a compression, they can then do surgeries that are to decompress the nerve, surgeries that have other high risk associated factors with it. But the other thing I want you to remember is that when these individuals are talking to you about this pain, they will say, doc, nothing makes it better. We ask them, what makes your pain better? What do you take for pain? Nothing makes it better. I have tried Tylenol, I have tried naproxen, I went to the emergency room, they gave me opioids, and I've been in the emergency room a couple times. They actually think I'm looking for drugs, but the truth is that those opioids don't do anything for me. And they put me in muscle relaxants and don't do anything for me. And it's true, none of these medications will take care of the trigeminal neuralgia. The only thing that is going to take care within 48 hours of starting the treatment is the intake of anticonvulsants, and the first drug of choice is carbamazepine. Obviously, with that and taking those drugs come some side effects. That's why individuals that are taking these drugs have to go every 6 months to have blood work to check that they don't develop aplastic anemia. But the patients will say they will love you because they will think that you gave them a magic drug because they really within 48 hours the pain is under control. Because of the anticonvulsant, there are some side effects as well of the drug that they may make them more lethargic. And if they are elderly patients, that may increase their risk of falling and then having fractures. So, but it is living with that pain versus taking the drug. And sometimes they don't want to deal with the side effect of the drug and they go to neurosurgery to have the compression if the compression is confirmed with imaging. Comments, Dr. Crow, Dr. Katu?
So you do need to know as a general dentist about this because you will have people referred to you from their physician because they think it's a tooth problem. And I've had, I think, 3 recently, or, within the last number of years. The first one came from a physician who she comes to the office to say, well, my doctor sent me because he thinks I need new dentures. So she'd been a dentist for years, and the physician felt that she needed new dentures to take care of her pain. And as I'm taking her history, she's talking to me completely normal, and then all of a sudden just, and then she starts talking normally again. And a few minutes later, the same thing happens. And I said, is that your pain? So when you see it, there should be no doubt in your mind of the most likely thing it is. It should be very clear. It's just that you're not often the one who's physically present when they have the attack. But as I say, it is, I know of nothing else that looks like that when they have an attack. But think of it because I've had people referred to me for, they must need a root canal. Odontogenically, there isn't anything majorly wrong, and it gets missed by dentists, physicians. It's just something you got to keep in your mind. Think about the age group. Think about the history of it.
Dr. Gonzalez?
Yes, and
Dr. Crow?
who is talking? Catherine.
Hi, this is Catherine. I just had a question. When you anesthetize a patient who has trigeminal neuralgia, do you have to do anything differently, like managing them, or does that even make them feel better?
I did anesthetize one person who the concern was that it was an odontogenic problem. It didn't seem to make a difference. I used Marcaine to do a longer lasting anesthetic because they weren't having the attacks in the chair, and I wanted to see if it made a difference. But that's an N of 1, so I don't know whether that's typical or not. You want to find out if somebody already has been diagnosed with trigeminal neuralgia, and if they're not well controlled, because even though these meds here are there, sometimes people will be controlled on meds for a number of years and then start losing some control on the meds. And there's other things they try to do, but there can be medication-resistant trigeminal neuralgia. In those patients, you want to find out their trigger, because it could be that just manipulating the cheek could be a trigger, which will make it very difficult for you to do a local anesthetic. But, it could be that if their attack is over here and you need to do something over here, you just want to find out, are they well controlled on their meds, and hope for the best, because you don't want to be injecting someone who suddenly does this. That's not good.
Okay, thank you.
Yeah, nothing else to add, Catherine, just that know the triggers, because your dental work could be a trigger in a non-well controlled patient.
Okay, thank you.
I just summarize what Dr. Crow said, and I'm not adding anything else. Thank you. The next one that we will cover is going to be glossopharyngeal neuralgia. So now a question for you, and we have, I only see very few names, so I will go to Joseph. Joseph, what do you think this patient is going to complain of? It actually is a question that is not in the slide, so that's good. Joseph?
Yes.
Uh-huh.
Oh, maybe ear pain or temporalis pain.
Well, it could be ear. I take the ear part based in the next slide. The other thing that I want you to remember, Joseph, they cannot swallow. The swallowing is going to actually trigger their pain. So these are the patients that a lot of feel like this, and they really don't want to swallow, and they are drooling, not because they are incapable to swallow, but because the swallowing may trigger that pain. Okay? So similar in terms of trigeminal, it being associated with multiple sclerosis, is between 40 and 60, higher in females. I cannot imagine, well, a couple minutes is when the actual pain lasts. Electric type of pain, and swallowing is what I want you to remember, that they are capable to swallow, they avoid to swallow. And so we used to give them a little cup with cold water to swallow, and that will trigger the pain. It was not to make them suffer, but to try to replicate their pain experience. So that makes me walk out of my neuropathic. Then it went into the others, and we have odontogenic pain. Believe it or not, around 10% was the last time we did the statistics a few years ago. 10% of the patients referred to our clinic were actually odontogenic pain. And we did that game of differential diagnosis, so I'm not going to repeat this because you guys responded very well a few weeks ago. But remember, it could be a huge cavity. And we have patients coming with a hole in their tooth and being referred for TMB. And it's like, are you kidding me? Look at it, couldn't be any bigger. It's a big hole. So, it was not like this tiny cavity. It was a huge hole. It could be a vertical fracture, which they are very challenging to diagnose. But with new imaging techniques, we can actually identify them more and more. And as you know, because you actually answered my question a few weeks ago, these are individuals that if they have a fracture, biting on that particular tooth will trigger and replicate the pain. I still have hard time with this periodontal pain, but it's in the textbook. I don't think how somebody can confuse this with TMD, but it's one of the artificial pain that you could have. What I remember about perio abscess, about patients telling me is that, how you make it better. They will tell you, I take my nail and just put it in between, or I pull a bobby pin out of my hair and do that, and it feels good. It hurts, but then it feels better, and something white comes out, and doesn't taste good, but it feels better. Well, that's called draining of the abscess. And then you could have coronaritis that it could be causing pain due to secondary infection and trauma to the tissue. So these kind of are going to be extremely, extremely easy for you to recognize, because that's your everyday. Things that are going to be more challenging are conditions such as atypical facial pain or phantom tooth pain, which I put it within the neuropathic domain, right? Neuropathic domain. It could be either local or it could be a central neuropathy. But technically, these are individuals that already have the root canal. The root canal, let's say, that is up perfectly done, and even after taking the tooth out, they still saying, you know what? When I get my pain, it's like I have my tooth right there. It feels like a tooth pain. And we can test if it's local or peripheral neuropathy related by applying local anesthetics in the area and see if the pain goes away, or if it's centrally mediated, definitely it have to be treated with other medications. And the question has come in the literature a lot if these patients actually can receive dental implants. Imagine they have the pain, they did 20 amalgams, a root canal, 5 crowns, and finally they take the tooth out, and they still have the pain, but now they don't like to see the hole in their mouth, so they want to put an implant in. Are these individuals candidates to have the placement of the implant? And based on my understanding of the literature, is no, because they will continue to have the pain, and then after you place the implant, they will ask you to take the implant because now the pain is worse and they want the implant out. So be aware of this atypical odontalgia pain. And how long the pain lasts? Well, it could be minutes to hours, continuous. Usually it's very localized to the area. You may feel as that electrical throbbing, sometimes burning sensation. I have never seen in our patient population to be associated with paresthesia unless has been a mechanical damage to the nerve to a dental procedure, most likely an extraction, and they respond to local if they are peripheral neuropathic conditions, and history of poor response to dental treatment. Don't think that because you are the new dentist, now everything will be wonderful with you. If they have that history, you are going to be the next and the next and the next in terms of providers that are making the pain worse.
So I'd like to just break in here because I do want to emphasize about implant placement. I think it's pretty clear that if somebody has ongoing neuropathic pain that we believe is atypical odontalgia, they are not a candidate for an implant. But what if it is resolved? What if their medication has taken care of this and they're doing fine? Are they a candidate then? Well, the experts in the field, and we all know that that's not the highest level of evidence, but the experts in the field really do not recommend implants, even in somebody who has resolved in that area from their neuropathic pain. So the concern is that you could re-trigger it, because we don't know what started it in the first place. It could be re-triggered. And so you just need to be aware of that even if they're better, if they had that, it's still controversial about whether you should put an implant in. Maybe it'll be fine, maybe it won't. But having patients that suffer from neuropathic pain, they have a difficult time. And as a result, you as the treating dentist will have a difficult time. So.
And maybe we can mention as well when we go to treatments, Dr. Crow,